It is rare that glossopharyngeal nerve is injured in isolation. So let us talk about the vagus nerve then. Vagus nerves comes from the same nuclei. There is only difference of the parasympathetic nucleus. Let us discuss the nuclei. There is nucleus ambiguus. There is special visceral efferent fibers. It supplies the muscles of the pharynx, the muscle of the larynx, the muscle of the palate. Then there is parasympathetic dorsal vagus nucleus that is different from glossopharyngeal nerve. It supplies the all of the parasympathetic supply of the thorax, the abdomen, all the way to the two-thirds of the transverse colon. And it is receiving fibers from the glossopharyngeal nerve, carotid sinus, so that in response to the pressure changes, heart rate can be adjusted. It is receiving fibers from autonomic fibers in response to the emotional stimulus, heart rate, breathing rates are adjusted, and it is also receiving some other inputs also from the reticular formation and other things. Then there is nucleus of tractus solitarius. This is receiving both special visceral afferents and general visceral afferents. Some taste fibers are also traveling with vagus from the posterior most part of the tongue, and from the some of the palate some vagus fibers are running. And the general visceral afferent, all the visceral sensations coming from the viscera, including the esophagus, stomach, liver, all the reflexes that you read there, they are coming from the general visceral efferent fibers to this nucleus tractus solitarius. And then comes the spinal nucleus of trigeminal nerve, especially around the ear. There are some general sensations are also received. These are the general somatic afferent fibers, and they are coming and terminating in the spinal nucleus of trigeminal nerve. These are about the vagus nerve. Let us discuss its course. It originates from the brainstem the same way between the olive and the cerebral peduncle. It exits through the jugular foramen, and within the jugular foramen there are nuclei. There is superior ganglion of the vagus nerve and inferior ganglion of the vagus nerve. It then moves down along the internal carotid artery and jugular vein and in the carotid sheath into the neck. Till here, the pathway is same for the right and the left side. For the right vagus, I'm not talking only about the pathway, not the branches. It moves down in the carotid sheath between the artery and the vein, common carotid artery below, internal carotid artery above, and it is running between the two. So it will be lateral to the carotid artery, medial to the jugular vein. As it will move down, it will right side, it will move in front of the right subclavian artery, moves behind the root of the lung, goes to the back of the esophagus, moves to the diaphragm, and it will lead to the celiac ganglion and will go on to supply all of the small intestine and large intestine up to the two-thirds of transverse colon. The left side have a little different pathway. From the top to the neck between the common carotid artery and the internal jugular vein was same. However, as it moves down, rather than the subclavian, it moves on the lateral aspect of the arch of aorta. Then again, same back of the root of the lung, but front of the esophagus. That is the anterior vagal trunk. Then it moves down to the stomach, and it is the major one that is responsible for supplying the stomach part of the duodenum and the liver and gallbladder. These are the supplies that are given to it. So these branches are shown here. The branches are shown. There are meningeal branches that are going to the back to the meninges. There are branches that are going to the ear. These were the one that were general somatic afferent fibers. Then other branches, there will be pharyngeal branches that will go and form the pharyngeal plexus. That will the all the muscles of the pharynx. It goes to the palate region also, and they will supply all of the muscles of the pharynx except one muscle that is supplied by the glossopharyngeal nerve, that is the stylopharyngeus. These are the muscles that supply all the muscles of the palate except one muscle that was supplied by trigeminal nerve, tensor villi palatini. And then the nerves that are going to supply around the larynx, the nerves that is going to go on the upper aspect, superior laryngeal nerve. It will be accompanying superior thyroid artery. It will have internal and external branches, sensory and motor respectively. And then these are superior laryngeal nerve, and then there will be a recurrent laryngeal nerve. And recurrent laryngeal nerve story will be different on both sides. On the right side, you saw that recurrent laryngeal nerve will be exiting in front of the by arching around the right subclavian. You can see right subclavian, it goes around and it will travel up. On the left side, it is around the arch of aorta behind the truncus arterio, behind the ligamentum arteriosus. Then it will move above between the trachea and esophagus. So that is the difference between the two. On the right side, it is coming back around the subclavian artery. On the left side, it is coming back around the arch of aorta and the ligamentum arteriosum. So that's in the thorax. In the thorax, the branches that are going to be supplied are the paracardic plexus, or everything will be slowing of the heart rate and all that. Branches to the lungs, branches to the esophagus, and as we move down to the abdomen, it will going to supply all of the abdominal viscera all the way to the 2/3 of the transverse column. That's the vagus nerve, and that's the picture in the Netter's Atlas. I'm not going to go through that. That has discussed all of these things that we just did. Clinical correlations: the injury of the vagus nerve leads to the failure of the motor component of the gag reflex. The person does receive the noxious stimulus through the glossopharyngeal nerve, but it but in what happens is that it cannot contract. So there is dysphagia, there is inability to swallow properly, there is inability of swallowing properly, there is a pharyngeal reflex, and there is a paralysis of the soft palate. What happens is that if you open your mouth, you can see a tag of tissue hanging behind in the midline, that is called uvula in the midline. Both of the sides of the palate are pulling it towards itself and it has balanced out. However, if one side is paralyzed, the healthy side is pulled the uvula towards itself. So if you read about the movement of uvula towards one side away from the midline, the uvula is pulled towards the normal side, the uvula it's pulled away from the paralysis side. So that's the MCQ we're going to be asked. And due to the soft palate, there will be nasal tone of the sound, something like this. And when you drink water, it will come out of your nose, that is called nasal regurgitation. It supplies the muscles of the larynx. That's a whole topic we have discussed in the larynx. The video is available on our channel. The larynx, the different degree of injury to the different branches of the vagus nerve lead to majorly affecting of the sound, that is dysphonia. But there are other issues also, like the blockage of the airway and things like that. So that's the clinical correlations regarding vagus nerve. Assess